Okay, well, I'm very excited for this next section. I titled this "The Top 5 Tips and Tricks I've Learned in My Career About the SI Joint." And for these 4 surgeons that came up here, they're all senior surgeons. Same thing with this afternoon round, the lightning round. So the surgeons that we selected for this particular section have just an unbelievable amount of experience. And I know I'm looking forward to it, to learn something. I think we'll all be able to learn something from these surgeons. So I think we'll start off in the order with Dr. Donner, Dr. Kibsgaard, Murakami, and Sturson. So Dr. Donner, if you want to come up, start, and then we'll roll down the list.
Well, thank you again. And one of my, these are my disclosures, President, and we'll have a commercially available product for the SI joint in the next couple of months in the United States, so that's my disclosure. You know, my main disclosure is I do have Woody Cross's phone number on speed dial. So that's one of my tips is, you know, I need advice or I need a tough patient or someone wants to come to me, needs revision, you know, he's the guy. Obviously, the diagnosis is critical. I mean, that's being redundant, but next session after lunch, we will be getting more into that, and I'm on that, so I won't overdo it at this time with my 5 tips and tricks. Patients are complicated, we know that. I mean, there's one here, this lady of mine, you know, I look at the pain diagram first. That's one of my key things. I pull the chart out of the door and look at that and see what I'm up against. You know, those lines and dots are all over the place for all the different spines and other problems that I see. Then it's a different conversation. But this lady is someone I knew. I did her disc replacement that, you know, over time, it worked for maybe 15 years. She developed facet pain, so I had to end up fusing the 5-1. She had an SI fusion that had hardware in it that worked very well. The hardware was bothering her, but she came in and was now saying, I have SI pain on the other side. Please do an SI joint fusion. And here I thought, well, this is gonna be an easy one because, you know, she's so experienced with her pain and I've been around the block doing all her surgeries and now I know her well. And the bottom line is, no, we need to evaluate this more. And the simplest thing I do when I do an exam is I start with the lumbar spine because I think that's one of the main pain generators I'm familiar with and know how to work up better than hips. So I start there. If they have any significant pain that radiates into this area that's bothering them in the buttock, we'll say, instead of saying the SI joint or around the pelvis, I don't even start doing any workup on the hip or the SI joint. I'm looking at the lumbar spine because I'm not really overstraining it. So one of the first things I do, besides all the things we've heard, is look at the lumbar spine. And then when you get the imaging, in her case, she had, you know, right lateral recess stenosis. She wasn't getting the full radicular symptoms. So I go and further work them up with, on my own. I do this in my own office under fluoroscopy. I'll do the facet injections. I'll do the SI joint injection. In her case, I did an epidural and relieved her pain. So she went on to have a decompression and not an SI fusion, which she thought she was coming in to get. So that's where you can get tricked. And again, I do myself, and it's only because when I first came to town in Fort Collins, Colorado 35 years ago, there wasn't anybody really doing these types of workups, or they weren't doing them adequately. And even now, when I send someone for a CT-guided SI joint injection at the hospital, they have a physician assistant do the procedure, no contrast, and like, this is like a waste of time. So we're really frustrated. You have to have these kind of institutes and other people to back you up and able to do this right. Obviously, number 2, you need to master the anatomy. It's pretty clear that the pelvis has a lot of anatomy there that overlaps and it's very complex and there's a lot of dysmorphism. So not only in the bony anatomy, but also the vascular anatomy. This is more traditional, but you can find many of these studies where the vessels can be in places you weren't counting on. So you have to keep that in mind. And I know some surgeons that actually do an angiogram in a way through IV contrast to outline it before they'll even, you know, venture because they've had some bad experiences. And you only need one of those to get a heart attack quick. Obviously, besides the anatomy itself, you need to be able to master the correlation, you know, with what you see on imaging, not only on the CT scans, but when you're in the operating room. So that's pretty much an obvious statement in a way. And some of the ways to do that is to make sure you're getting the most accurate inlet and outlet views. and using the right views before you start to venture in placing an implant, especially, sharp instruments in the pelvis always make me nervous. So with that, I believe in, like Dr. Cross here, in traditional AO fusion principles. This was a technique I used to use early on by removing the PSIS back here, packing the bone after I took the ligaments out and the joint as much as I could safely, and then did rigid fixation and getting that type of fusion. What I think back about this, I was realizing is I can take out the ligaments, I can take out the cartilage from this direction. Yes, it is a little more open, but it wasn't terribly open, no more than a lumbar fusion. So I found I was getting good results with this technique, so I kind of stuck with it. And the technology that we'll be releasing soon follows the same kind of principles, but we follow where you do most of your injections here in the posterior inferior portion of the joint. Using that, since that's where I've been doing injections, and I got good results with pain relief, why not just use that corridor for our technology? So the way that's done, you can see, you can go down this posterior inferior portion right where you would do your injection, and over a guide wire, you can prepare this part of the joint and then place this implant, this is called SI Desis X, over a cannulation with big bone windows. It has fixation features that also have compression types of features. And what I like about it more is I can keep it posteriorly, and I can pack the bone into the front of this area that we prepare with a hand drill and some rasps, so I can get early good bone graft incorporation with autologous bone, and you can see it nicely outside of the implant. So when you're imaging it with a CT, you're not getting all that distortion. And again, I do like using blunt instruments. I don't like putting sharp pins in. I'll start with a sharp pin, for example, go through this with a Jamshidi, which I like because I use it with kyphoplasties and other things. It's very comfortable in my hands. And I can hold it with a towel clip or some type of instrument, so my hands are out of the way. I can push it down through the skin right to the lateral cortex of the ilium, and then with a mallet, I just tap it across. I don't like drilling in the pelvis, especially with a wire, and this seems to make it easier because then I just take out the trocar, put in a blunt wire, and just push it up to where I'm comfortable, and I don't have to worry about penetrating the pelvis. And then I just do my work over that, or you can use that with image guidance the same way. Obviously, the last thing is being prepared for complications. Everybody's had one of these going laterally. I mean, it's almost a heart attack when it's bleeding that fast, and you're trying to figure out what to do, because especially you're making a small incision, you're doing it percutaneously. The first thing you're gonna do is reach in there and try to clamp something, and who knows what you're gonna get, and it gets to be pretty frightening. So I think I'm always prepared after having one that I have something ready in the back table to put some pressure on there and just kind of use that and not go in there with a Bovie or bipolars or clamps and clips. And there's one I had to pretty much hold like that and get the one I had down to the radiology suite. So be prepared to save yourself a heart condition. Anyway, thank you.
All right, Dr. Kibsgaard is next.
My name is Thomas Kibsgaard. I'm going to talk later so I can introduce myself later today. I'm from Norway, and I work in Oslo, the capital of Norway. We are 5 million people in Norway. And I try to operate on the SI joint. I cannot show the same results as all the American experts, unfortunately. We're going to have 2 papers later today, explain more or less how we have done it and how our results are. The SI joint, when you start to look for it, you see it everywhere. And that's the problem for spine surgeons. When I started to talk about this in meetings, they started to see it. And if you see Oslo compared to Mayo, we don't get the patients worked up. We just got the referrals. Probably this is the SI joint, find it out, treat it, help me do whatever we want. So every patient we got referred is not worked up at all, and they're not diagnosed. So it's the problem if you have a bad result? Is the surgical method is wrong? Are we not able to diagnose it? Do we use the wrong outcomes? Or is it so that we have a different population than the rest of the world? I don't know. So the 5 things I've learned, the diagnosis is the key to success, and Woody talked about it, and everybody else talks about it. So rule out everything else, and that's most of the problem when all the referrals, they haven't done all the workup, they haven't ruled out the hips, the spine, spinal stenosis. It's common that we have patients with spinal stenosis, and if you reveal, decompress them, the SI joint problem goes away. So, and when you are in doubt, surgery is probably not the solution. And when I started all alone, and don't do that. You need a multidisciplinary team, physiotherapists, pain doctors, surgical colleagues that actually know something about this. So collaborate with people that actually have some interest in the SI joint problem. And we have talked about revisions. I have done some revisions, and I don't think it's that easy, especially when it's stuck in the sacrum and not in the ilium side. We have a lot of some patients that have that, and chisel out this one close to the nerve canal. It's sometimes very dangerous, I believe. So this is some of the revisions I've done. We'll talk about it later today as well. And when you read and learn, be a little bit critical, because in the literature, there's a lot of bias. And the study designs are sometimes quite hard to understand, and there's a selection bias in the patients. And there are also an industrial bias with the compliance problems. We have published 3 papers on the outcomes of Scandinavian patients, and they're not as good as the American results. We're going to present 2 of them later today. And the last one, if you operate on patients, please follow them. And we have, many countries have national spine registries. They're not designed to follow SI joint patients. That's the problem with these types of spine registries. And we also have local quality registries that you can actually follow the patients 100%. And if you do that, you probably will see what the results of your surgeries are. And we're going to present our local quality registry later today as well. So this is the tips and tricks from me. Thank you very much.
Just outstanding. Thank you very much. Dr. Murakami is next with his tips and tricks.
Anatomy of SI joint. Bernard defined SI joint consists of the articular compartment and ligamentous compartment. In response to the structure, 2 types of SI joint, intra-articular injection and peri-articular injection. Intra-injection is have gold standard in diagnosis of SI joint, but low success rate. Very difficult with my technique. I developed peri-articular injection. Peri-articular area, the whole section divides. And the success rate is very high and easy. Effect of peri-injection was compared. 36% of intra-articular effect. The peri-articular injection was 64% effective. About 2,000 cases SI joint pain originate from peri-articular region. Our data, typical SI joint pain, gluteal pain, and SPSS. In 80% of patients, peri-articular injection was effective. Only 20% required additional intra peri-articular injection. Strategy for SI joint pain: first, peri-articular injection. If necessary, intra-articular injection should be added. This arthrogram is efficient to diagnose SI joint pain. A useful score who distinguish from lumbar spine disorder is sacroiliac joint score developed. Three out of 10 items, 3 items: gluteal pain at PSIS, growing pain, STL. These 3 items significantly higher in patients with SIJD than those with LDH and LSS. SI joint score, total Q point produced, PSIS 3 point, growing pain 2 point, 2 point, pain, sitting pain 1 point. SI joint shear test positive 1 point, PSIS or STL tenderness 1 point, respectively. For the differentiation of general lumbar and gluteal pain, cutoff score of 5 point, sensitivity 77.4 degree percent, specificity 76.4%. Diagnosed arthrosis for SI joint pain in Japan. Reference to first physical examination, reference to SI joint score, end provocation test. Next, diagnostic injection. First, peri-articular injection, more than 70% pain relief. Yes, definitive diagnosis. And next, intra-articular injection, additional pain reduction more than 70%. Yes, definitive diagnosis of SI joint. Both injection is not effective. The others disease suspected. The tip of peri-articular bedside injection. Bedside injection. Peri-articular injection are possible, but intra-articular injection impossible. Need fluoroscopic guide is necessary. SI joint injection has been popular in Japan because the peri-articular injection can be performed easily at the bedside. Pointing by one finger test near PSIS, caudal needle directs insertion toward area 2 or 3. Proximal to PSIS by one finger test, proximal needle directs insertion about area toward area 0 or 1. It is important, most important to find the pain site. When the needle reaches the resource of pain, the patient will say, "This is my pain." If needle tip only a few millimeters away from the source of pain, pain is not reproduced. To block the exact pain site will have a stronger and longer lasting effect. Transition of SI joint fusion surgery. At first time, posterior fusion with 3 screws could not enough relieve pain, and develop anterior fusion of SI joint. 2001 years. Extraperitoneal reach and anterior of SI joint with screw and plate and screw to fix the SI joint. But post-op result, sitting time and walking time improved significantly. But anterior fusion is relatively invasive. Change it to posterior fusion from 2016 by Kurosawa. Hip sacroiliac spine syndrome to merge with lumbar spine disease and sacroiliac joint disorder is not uncommon. Bernard, 39%. Hip spine syndrome, pathological condition that hip joint and lumbar spine are affected each other, is known as hip spine syndrome. But SI joint located between hip joint and lumbar spine, and more directly affected by hip joint or lumbar disorder, we defined as respectively sacroiliac spine syndrome, hip sacroiliac syndrome. Each frequency at Jeico Sendai Hospital, SI joint disorder only 55%. Sacroiliac spine syndrome 30%. Hip sacroiliac syndrome 15%. In case of complication, SI joint disorder often do not improve without treatment for lumbar or hip joint disorder. Some SI joint pain can be relieved only by treating these disorder. And when SI disorder is not improving, lumbar and hip joint disorder should be explored without sticking to the treatment of SI joint. Thank you.
Thank you. All right, and to close it up, Dr. Sturson with his tips and tricks.
So, thank you very much. I had to think a lot to be sure which are my 5 tips and tricks. A so long career. But number 1 is the basics. It's the basics. It's a history of the patient and do a proper examination. I think that if you try to treat it without these basics, you are in trouble. And you have to exclude spine and hip pathology when treating the sacroiliac joint. Number 2, do a diagnostic block. I think it's very, in my clinic, it's easy because I can do the examination before and after the sacroiliac block. And I can be very clear if the block is good. If this block is not good, I have to re-examine the patient another week. Number 3, inform the patient. It's very important to explain what the patient can expect after surgery. If they think that they, after surgery, can run the marathon, I think you shall tell them they shall seek another doctor, because you can't run a marathon after sacroiliac fusions. So that is the most important. You go from severe disability to moderate disability on overall, and that I think that is very, very important to tell the patient. Number 4, imaging. It's not diagnostic, but it's important to exclude other things. You need to exclude tumors, inflammatory disorders, degenerative disorders, and also the spine. So I think imaging is very good, and the best if you have a very good imaging from MRI with good frontal and axial views. Not every institute do that in a very proper way, unhappily. But that is, I think, that is if you have these figures, you can be quite clear that you have not other problems. And the last is the post-operative rehabilitation. I think it's very important if you do surgery in the buttock area. These patients, they have very bad muscles. If you have a long history of pain, you have bad muscles. So you need a good physiotherapist to help you to return to good muscles. I think that is so much more important than you can imagine. And there is also one thing with those Ehlers-Danlos syndrome. It is 5.5 now. They doesn't matter if they heal perfectly well in the sacroiliac joint. They will still have pain on other locus. But they will be able to walk. That is a difference. But they will still be in pain from the spine or the hip or whatever. Thank you.
Thank you. All of those were amazing. Thank you for pointing those out. Any questions from the audience or any comments about imaging or physical therapy or anything else that any of the surgeons? We have a lot of experience in this room, so if anybody would like to chime in, that'd be great.
Thank you very much. So I'd like to ask Bengt. So I understood that I remember that you carefully differentiate the irritated joint and inability joint regarding the sacroiliac joint problem. So I think so. If the patient have a load transfer impairment, you diagnose the patient have a sacroiliac joint inability. But so you carefully differentiate that the irritated joint. So you examine the patient, you touch the softly, but the patient have a painful. You judge this patient have a irritation, just only irritation, not inability. So my question is that if the patient has both conditions, the irritated state and inability state, how do you differentiate that?
Well, the question was about inability to load, and I think it's very important that the patient group that I want to do surgery on. If you have irritation in the pelvic area, and that most likely it is those who have maybe a very, very small degeneration or extra-articular problems. Then I try to, they send them for physiotherapy, I give them anti-inflammatory drugs and so on. But if I'm unable to load, that is a patient group I think I want to do surgery on. And I think that's the trick. If they can't load before the block and they can load after the block, then that is the game changer. And the interesting thing, when I started my career, it was discussions about instability. But now I think we shall talk about stability and ability to load. That is my clue.
I think I had a question to you and Dr. Kibsgaard about physical therapy, namely, and the role that plays. And then, again, my practice is a little unique because I typically only see patients that have had it for years. I think both you and Dr. Kibsgaard see patients who have not been diagnosed before. So in those patients with physical therapy and other modalities, when are they ready for surgery? And how long do they have to have it for a year? Do they have to have it for 4 years? Do they have to have it for a month? Like, where do you draw that line, and how aggressive do you get with non-operative methods before you indicate them for surgery?
You can start.
In the beginning, when we got referrals, all the patients had a 20-year history of sacral joint pain, and they have tried everything. But everything isn't everything. And if you have a physiotherapist that actually are pretty good at this, they do something else than everybody else. But we really try to work them up, and many times we don't see them again. But that's how we are organized. That's the problem, because if the physiotherapists truly believed in surgery, they actually referred it back. But there's some problems that they don't want them to have surgery. So if I'm going to operate on them, I have to do it if I got the referrals. But if I send them out to a physiotherapist, I probably never see them again.
Well, that is interesting because in Sweden, the patients come back. But I think it's very important to have a proper physiotherapy before you do surgery. Because also according to the European study of minimal invasive surgery, we saw that out of those, the half group who was operated on, they were enough good, half of them enough good with physiotherapy, and they didn't want to go do the crossover because they felt they were enough good. So it's about the reaction for the patient. Do you want to have surgery or not? Is it good enough with physiotherapy? And I think that most of the patients don't need to do surgery if you have proper physiotherapy. But we have a problem in our country, but not so many physios are so skilled that they know because this is basic physiotherapy. It is like belly and back, and so it's not so tricky. But then you need to touch them. You need to work with the patients, and that is they forgot that in many cases in our country.
Thank you.
Yeah, Carlton Reckling, orthopedic spine surgeon. That my disclosures, I'm now the chief medical officer at SI Bone, and my role there is to bring information from academic learnings in situations like this back to my organization so we can communicate better to our customers, which are surgeons, which are physios, etc. Regarding the physiotherapy comment, not every patient with SI joint pain has the same functional deficit. Different patients need different sorts of physiotherapy. The young woman with abdominal diastasis and pelvic floor problems needs different physiotherapy than the 60-year-old man with a degenerative SI joint. And I'm not sure that all our practitioners are thinking about this the same way, nor are our physiotherapists. So, I think it has to be the appropriate physiotherapy for the particular patient.
That's an absolutely great point, and it hits home because I have a lot of patients with true pelvic floor dysfunction, and they can't go just get core strengthening. They have to go to the pelvic floor therapist, completely different program. Right.
Well, I have a comment on that. I like this word, tailored physiotherapy.
Sure.
It should be tailored for the perfect patient, perfect physio.
Right. Agree.